Assalamualaikum and a very good day, everyone. This is going to be another asynchronous lecture that I'm going to explain you guys about the how exercise can help to prevent and to maintain or to handle cardiac diseases and its dysfunction. So a bit of introduction about this topic. Before that, I would like to just describe the definition about cardiac disease. So cardiac disease includes a number of health conditions, including coronary artery disease, myocardial pumping dysfunction, electrical conduction abnormalities, and valve disease. So you have to bear in mind actually cardiac disease. I would say we can easily divide it into two main factors, which are the modifiable and non-modifiable. And the modifiable is due to high level of low density lipoprotein or LDL, and also high level of TG, which is triglyceride. And both of these we can simply refer it as the hyperlipidemia, meaning excessive of lipid within your circulation. And then the next points of the modifiable that leads to cardiac disease is the hypertension. And of course, when the accumulation of plaque, lipid plaque and cholesterol plaque within your artery lumen, narrowing your artery lumen, it will increase the pressure since the area, the blood flow decrease. It will increase also in the blood pressure, and then could lead to hypertension as well. And then not just because of the narrowing of the artery lumen, it is also could leads to hypertension could also due to the hardening of your artery wall, which also call it atherosclerosis. Okay, so arteriosclerosis and atherosclerosis will mean two different things. The hardening of the artery wall is atherosclerosis, whilst the arteriosclerosis is the formation of plaque within the media interna of your artery wall. The formation of plaque within that media interna. And then the next modifiable factor is the smoking. Of course, smoking could lead to the hardening of your artery walls, and of course, obesity and type 2 diabetes could also become the risk factors of having a cardiac disease. And for these two, I've already mentioned it in our previous lecture. And all this modifiable is due to the inactivity or low level of cardiorespiratory fitness. So apart from the modifiable, there's also other non-modifiable, which has nothing to do with inactivity, but rather due to factor of age, meaning wear and tear of the circulation system, gender, difference, meaning that males are prone to have increase in cardiac disease compared to female due to the physiological differences and hormones differences. And then ethnicities. Okay, ethnicities is very much related to genetic as well. It's in your genetic, it's in your gene, whether you're prone to have to get cardiac disease when you're getting older. So yeah. And then low birth weight and poor fetal health could also become the factors of having a cardiac disease and leads to premature death. So so you have to keep in mind that cardiac disease is not always due to inactivity or low level of physical activity, but also it could also due to other factors of the non-modifiable. But you know, many evidence out there has shown that by performing physical activities, which could give a multiple effects of benefit to at least maintain the condition, healthy condition, although the factors, the pathophysiology of cardiac disease happen, it can bring the individual to better health by doing exercise. So let's move to the next one. So yeah, and then I'm going to explain the pathophysiology of the cardiovascular heart disease, or you can just simply say it as CHD. And CHD involved in progressive narrowing of the coronary artery lumen. So the opening of the artery, we call it the lumen, as you learn in your anatomy and physiology. And then it forms a plaque of cholesterol within the artery media interna, okay, of your wall, okay, of your artery wall. And then over time, okay, we'll build up the plaque, and then it narrows the lumen. Okay, this is due to the LDL, excessive amount of LDL in the circulation. Okay, will settle between of your media interna of your artery bed, and then over time you form a plaque, and then this plaque will eventually become bigger and making the lumen of your artery narrowed. And then at the same time, an inflammation tissue will occur, okay, in the endothelial cells of your lumen, the bed of your lumen. Okay, it become hardening. Okay, become harder, and then when it reaches a certain time, the endothelium, okay, the endothelium cells will burst and form a plaque, okay, and the plaque itself could block, okay, the flow of blood, and that could lead to the the particular area that gets supplies from blood will have doesn't receive oxygen, or we call it as ischemia. So yeah, and also the artery wall, okay, the endothelium, which I mentioned just now, will become inflamed. Okay, it could also harden, which leads to the atherosclerotic. Okay, become hardened, and then leads to the hypertension as well. So it may or may not cause ischemic symptom. Ischemic means receive lack of blood in that particular area, receive lack of oxygen in that particular area, it may or may not cause ischemic system, and it's depending on the severity of the plaque formation. When it reached a certain degree, of course, the ischemic system will occur, which is the pain, tightness of the chest. If it's occur, if the blockage happen in your artery that supplies to your heart, so of course you feel chest pain, then the neck area, and then to confirm this, okay, to confirm whether there is a blockage of that particular area due to the atherosclerosis, we need to confirm that by using the angiography, okay, meaning that scanning of your blood flow within your heart. And then of course ECG could also tells you something based on the wave form from the ECG, okay, electrocardiograph of your electrical activity of your heart. It could also tell you which parts of the area that didn't get enough supply of oxygen, or starting to died cells or tissues in that particular area died and doesn't function normally. So usually lumen occlusion of less than 50% will not cause symptoms of angina. So angina is a heart pain, okay, is a condition of heart pain. Okay, symptoms of angina or heart attack. Okay, so if the lumen occlusion or the area of lumen is less than 50%, we still didn't feel any ischemic symptom or heart pain, chest pain. And then cholesterol plaque that is unstable and rupture can lead to arterial wall and form another clot that can cause myocardial infarction. Okay, I'm going to explain to you this in my next video that I'm going to show you. And then myocardial infarction is a heart attack. So younger adults, age more, sorry, it should be over or less than, sorry. So younger adult of less than 50 years old. So younger adults less than 50 years old who has 50% lumen narrowing, have no symptoms of angina and acute myocardial infarction, and it can happen without warning, okay, from the unstable plaque. So I'm gonna show you some a video explaining what are the lumen cap, ruptured lumen cap, and an unstable lumen cap that can cause blockage of the artery lumen, and then leads to myocardial infarction, meaning heart attack. It can lead to heart attacks. Yeah, let's just watch the video.
This is the story of how too much cholesterol in the body can set up a process that spirals out of control and could cause a heart attack. Cholesterol is a useful lipid that the body needs to control digestion, make steroids, and maintain healthy cell membranes. Cholesterol is carried through the bloodstream in particles called LDL. Everyone needs cholesterol in the proper amounts. But if there is excess LDL in the bloodstream, it pushes inside the artery wall and accumulates where it doesn't belong. The body interprets this as an invasion that touches off a natural inflammatory process to try to limit the infection. Inflammatory cells are called into action, literally swallowing the invading LDL, until they form a lipid core inside the artery wall. Now, it's crucial to keep this lipid core away from the blood because the core has a strong clotting agent. The inflammatory process sets up a protective barrier by forming a cap made of a tough, fibrous matrix, and for the time being at least, the fibrous cap is strong enough to keep the plaque separate from the blood. But eventually, the inflammation breaks down and weakens the fibrous cap that was the last line of defense between the clot-causing lipid core and the circulating blood. This lesion has now reached its most dangerous state. And in this vulnerable state, the plaque is an accident waiting to happen. Any one of the
So this is the dangerous stage of accumulation of cholesterol plaque, where the inflammation cells become hardened and narrowing and become less thick at the edge of the nearly reach the epithelium of the artery walls, and it easily can rupture. And if it's once it's ruptured,
any typical daily stressors that are normally harmless could be the last straw for
increase the pressure, and of course when it increase the pressure of the blood flow in this, it could easily rupture this area.
Vulnerable plaque, triggering a rupture in the cap. With a cap rupture, there's nothing left to prevent the mixing of the plaque's clotting agent with the blood.
So when it ruptures, of course, a defensive mechanism of our body to form a plug to hold back the the ruptures, to block the ruptures from and repair it. And once it happens,
the likely result is a clot in the artery. Now, the extent of clot formation and the damage it may cause could range from minor to fatal. The most unfortunate ending of that vulnerable plaque story would be a large occlusive thrombus that causes the heart muscle tissue to die from lack of oxygen. If too much tissue dies, the entire heart can stop working, suddenly killing the patient.
Yeah, so that's basically the pathophysiology of cardiovascular heart disease. So, yeah, thrombosis will form.
I have to stop.
Okay, a thrombosis form due to
This is
the rupture of the cap. Okay.
That vulnerable causes the blood. The likely result, plaques clotting, a rupture in the cap. With a cap rupture, there's nothing left.
The rupture happens in the cap that forms a thrombosis, and the thrombosis will block the whole lumen. It depends on severity. The particular area tissues of that particular who get blood supplies of that particular area didn't get enough oxygen and blood supply, and eventually died, and leads to myocardial infarction. Okay. So yeah, as I mentioned, younger adults, less than 50%, who have 50% lumen narrowing, doesn't feel any symptom of angina, any symptoms of heart pain or chest pain, and it can easily, once the thrombosis form or the cap is ruptured at the lumen and block the lumen itself, it will lead to without any warning, it will lead to premature death or sudden death due to the malfunctions of the heart. So the risk of myocardial infarction or cardiac arrest will greatly increase if the reduction factors is not pursued. What are the reduction factors? Is the medication management, which I'm going to explain you what are the medication that usually cardiovascular heart disease patient will consume, that also leads to affect the response of the body to certain exercise. I'm going to explain that. And of course, the reduction factors, the lifestyle, change in lifestyle. Of course, as I mentioned earlier, although the factors of having cardiac disease could be modifiable and non-modifiable, but of course, by doing exercise, it can improve, the well-being of the patient due to certain changes happen in the body that supports and lessen the the comorbidities of the patient, and lessen the effects of the patient itself. Okay, the effect from the cardiovascular heart diseases. So physical activity of less than 27 kilocalorie per body mass per day possess greater risk to cardiovascular heart disease mortality than obesity. So physical activity is indeed still a main reason for you to experience mortality due to cardiovascular heart disease. And even though you have a person who have cardiovascular heart disease due to mortality due to non-modifiable factor, once get the caught into the disease, they will potentially stop exercising and bed rest, and this will worsen the effect, okay, that happens to the patient. So actually, they are the one who need to be encouraged to do more physical activity in order to get better life, better health, and to overcome a certain effects from the cardiovascular heart disease. So low physical activity, low physical fitness, which unable to walk 1 mile under 20 minutes, is a strong predictor for cardiovascular heart disease. So if you remember, there's one I would say tools in measuring the aerobic fitness of running 1.5 miles, which is equivalent to 2.4 kilometers, and you have to be able to run under 20 minutes to be classified as fit. Your cardiovascular system is it's in a well state. So so 2.4 kilometers running less than 20 minutes is the strong predictors of the prevalence of cardiovascular heart disease. So so exertion related to cardiac event. So American Heart Association Committee on Exercise Rehabilitation and Prevention estimates that 4 to 20% of myocardial infarctions occur during or soon after exercise. Okay, it can happen after exercise due to certain reason that I'm going to explain later, and the risk increases in the person who do not regularly exercise. Of course, for those who didn't do exercise, they will tend to have a potential to get myocardial infarction compared to those who regularly perform exercise. So you must you cannot discount this on person who regularly perform exercise, because they will also at certain percentage, okay, can get myocardial infarction during exercise due to certain reason. Because while exercising, there are certain things change in your body, especially the heart pressure will increase, the heart rate increase. That will lead to certain degree of mortality. Okay. However, you have to well prescribe the exercise in the progressive manner, rather than abruptly do high intense to avoid myocardial infarction to occur. So while exercising, the risk of myocardial infarction will increase 6 to 164 times in coronary heart disease patient compared when they are resting. So of course, for those who have CHD, okay, cardiovascular heart disease, the narrowing of the artery wall, they will easily rupture the artery cap, the endothelium cap, during exercise because the pressure increase, and this will lead to myocardial infarction. And yeah, so you must be precaution on that, especially for those who are, you know, age lesser than 50 years old, who didn't have any symptoms of angina, any symptoms of you know, myocardial infarction. They are the one who are vulnerable, okay, because without any signs suddenly will cause them a premature death. Yeah, however, a regular exercise will reduce this factor, okay? Because, you know, regular exercise can perform HDL that acts as a scavenger, okay, to get rid of the plaque that accumulated within the you know, the underneath the bed, the artery bed, and then, you know, increase the size of the lumen. Okay, of course you need that you know, in you know, in certain period of times, okay, to improve the condition. Okay, I believe you have seen this graph, which I have explained earlier. You know, increase in the exercise workloads actually will also increase in the rates of or degree of mortality. You know, expose yourself to death. Okay, so among sedentary people, if you perform you know, moderate or low level of exercise, of course the risk is, you know, it's not that high. I would say in moderate level. Of course, when you perform a regular exercise, moderate level of exercise, the risk factors will reduce, okay, because changes in your body will start to happen, and become, you know, stronger and resilient to a degree of risk to death. And then if, you know, the exercise is too heavy or too intense, okay, your risk factor of you know, of mortality will also increase due to, you know, stress that have that you know, against your body, like, you know, high blood pressure, increase in heart rate, and then you know, that could leads to, you know, certain vital to your body. Okay, if you do it in a broad manner, of course, when you do regular high intense exercise, you know, in a prescribed manner, or in a well manner, or, you know, suitable to your body condition, you become, of course, you become better. Okay. So yeah. So as mentioned, no matter if you are an elite athlete or sedentary people or cardiovascular heart disease patient, if you increase your intensity, or, you know, you perform a heavy, you know, exertion, okay, high intense exercise, you still expose yourself to a certain degree of mortality. Okay. So of course, for those who have certain cardiovascular condition, will, you know, will have a greater risk factor when they do high intensity type of exercise. So let's now look into the physical activity and exercise in prevention the coronary heart disease. So for this, I will explain how physical activity or exercise can help to prevent those who did not have cardiovascular disease from getting cardiovascular heart disease. So healthy adults should aim to perform physical activity of at least 1,000 to 1,500 kilocalorie per week. Must burn this range of kilocalorie, this range of energy per week in order to avoid the cardiovascular heart disease prevalence. And some people equate this to 30 minutes of activity per day. So if you remember, in my first lecture, I've already discussed, explained you guys the guidelines of ASSM, which requires us to perform at least 30 minutes out, activities that out from our daily routine or daily chores. Okay, do physical activity at least 30 minutes for you to have, a good fitness and prevent you guys from having certain non-communicable disease. And greater prevention of cardiovascular heart disease can be achieved by performing 20 to 60 minutes of more vigorous activities using larger muscle group of at least 3 times per week. Okay, this is the guidelines from the ASS, the new guidelines, which require us to perform between 20 to 60 minutes of at least more, at least 3 times per week or more, in order for you guys to, avoid or prevent yourself from getting any cardiovascular heart diseases. The mode of exercise that has been recommended is, at least moderate level of exercise. And sometimes you also need to perform a high intensity type of exercise occasionally. And how can we tell whether that's that level is high intensity or vigorous? Is, at least it needs to achieve, the lactate threshold. Okay, one at a time. Occasionally you have to, force yourself or cardiovascular system to certain type of stressor for it to train itself and become more, steady and strong. So these are the, exercise mode that has been recommended by the ACSM. Perform more, more than 50 to 75%, I would say, moderate level of activity, moderate level of oxygen consumption and heart rate reserve, or should be end here as well, or end. Okay, let me just fix this first. Okay. So end or 65% to 80% of maximum heart rate or heart rate reserve. So as I mentioned, sometimes occasionally you have to perform vigorous type of exercise. Vigorous defines as, at least achieve your lactate threshold, and then attaining RPE or rating perceived exertion between 12 to 15, which is the somewhat hard to hard. If you're familiar with rating perceived exertion, ranging between 6 to 20, scale of 6 to 20. So at least you must achieve 12 to 15. Okay, somewhat hard, that can be categorized as the moderate to high intensity exercise. Okay, so these are the exercise mode that you need to do in order for you to prevent yourself from getting any cardiovascular heart disease. And what if you the person or patient already caught into cardiovascular heart disease? So how exercise can act as the rehabilitation strategy to overcome certain condition. Of course, exercise can help to help them to improve their well-being. For those who have diagnosed with cardiovascular heart disease, both aerobic and muscle strength training are shown to be beneficial to cardiovascular heart disease. So you can, make a variety of your client's training program by mixing up with both aerobic and muscle strength. Of course, there's certain, guidelines that have followed due to the patient condition, health condition that I'm going to explain later. But yeah, in overall, you can approach aerobic muscles and strength muscles training for them. So aerobic exercise need to perform more than 3 times per week at, moderate to high intensity, okay, of VO2 max or VO2 reserve, VO2 max reserve for more than 20 minutes, okay, because this is commonly what's suggested by literature that can produce, high density lipoprotein, where the lactate fate, okay, the lipid in your circulation can change low density lipoprotein into high density lipoprotein because they are come from the same source, at the same time when high level of HDL been synthesized, of course it will reduce the clotting or the cholesterol plaque at the lining of the artery wall. And by performing at least 20 minutes, this is the I would say minimum time that when you perform low intensity exercise of 20 minutes, okay, low meaning 50 to 60 or 70 is considered as moderate already. The threshold of moderate intensity, because more than 70 is already high, okay, level of exercise, high intensity type of exercise. So make sure it's 50 to, I would say, 70% of VO2 max and perform it 20 minutes. This will promote lipolysis or utilization of fat as the source of energy. And when lipolysis happen, this will trigger change of both chylomicron and also low density lipoprotein back to the liver and change it to high density lipoprotein. Before that particular high density lipoproteins particles will act as the scavenger to the cholesterol plaque that lines the endothelium cells underneath the endothelium of your arteries. So yeah, that's why they suggest that at least three times a week of moderate intensity of 20 minutes, okay, to allow the formation of HDL to happen. And occasionally, of course, you have to perform high intensity type of exercise from 70 to 80% of VO2 max, due to because in order for you to strengthen the heart muscles of your patient, okay, to adapt with that particular demand. Okay, so yeah, always a mixture between aerobic and also strength training that would help moderate and also occasionally too. And of course, I would say it depends on the condition of your patient. Okay, if it's elderly, of course you have to just focus on rather it's individual, I would say. Okay, it's individual depending on the individual capacity to perform exercise. So, and then studies has also shown that you need to perform this program of at least 6 weeks to see any changes. Okay, this is what has been reported by most scientists. 6 weeks is the minimum time duration to see changes. Okay, changes in their cholesterol level, or their well-being. And then of course, as I mentioned in my previous lecture, doesn't really necessary for the persons to feel stronger. Although the training program is low to moderate, still there is changes within your body that you didn't notice, and it's still good enough to encourage them to continue to perform exercise. Okay, and then it is important to consider low, moderate, and vigorous intensity on cardiovascular heart disease patient relative to their individual capacity. So I've already mentioned this. And then this is the multiple effects that will happen to your body when you perform exercise. So you can look at this through, say, potential cardioprotective effects of regular physical activity. So what physical activity or exercise can do to protect your cardiovascular system. So it acts as anti-atherosclerosis, meaning anti-hardening of the artery wall. So it improves blood lipids or lipid ratio, lower the blood pressure, of course, when the wall of your artery is not hard, okay, it's flexible. It will lower the blood pressure at the same time. So yeah, and then reduce adiposity. Of course, when you exercise, you produce more, hormones, lipase, for example, to reduce adipose tissue, to utilize the adipose tissue. And then increase sensitivity and reduce inflammation. Yeah, especially for those who have, as I mentioned just now, okay, the hardening of the artery wall is due to the inflammation, and by performing exercise, it can reduce the inflammation. And then, of course, psychologically, it will lesser the depression, and then lesser stress and increase in social support, because when you perform exercise, our brain will secrete more, endorphin hormones, which is I would say, drug therapy to make us feel happy. Okay, the endorphin hormones will release when you perform exercise. And then anti-thrombotic. Okay, thrombotic, if you remember, thrombotic, when the cap of endothelial, inflamed endothelial ruptures, it will form a thrombotic that block the lumen to allow blood flow of the particular artery. So exercise can act as the anti-thrombotic, okay, which will decrease the platelet adhesiveness, increase fibrinolysis, and decrease fibrinogen, and decrease in blood viscosity. Okay, and then anti-ischemic. Okay, exercise can perfuse oxygen to the muscle, so it also act as anti-ischemic. Of course, it reduce the myocardial oxygen demand, and then increase coronary artery flow. It reduce endothelial dysfunction, increase EPC and CACs, and increase in nitric oxide. So nitric oxide is the element that allow blood to perfuse to your organ. Okay, nitric oxide. If you consume foods that contain nitric oxide, it will help the oxygen to perfuse within your muscle tissue. So yeah, that's nitric oxide. And by performing regular activity, it can increase nitric oxide production as well, and allow perfusion of oxygen to your muscle tissue. And then, of course, exercise can also act as anti-arrhythmic, meaning that it will regulate your heart the rhythm of your heart in a normal manner. Okay, so that's basically what exercise can add to your body. So it gives a multiple effect. Okay, unlike any particular dose that you give to a patient, if you have, a patient have cardiovascular heart disease, they will be given or prescribed a certain drug that can only affect one things at a time. Okay, for example, beta blocking. Okay, usually, or maybe aspirin. Okay, for those who have family members who are CHD patient, doctor will prescribe them with aspirin. Aspirin is the anti-platelet, meaning that will to increase the blood to reduce the blood viscosity. Okay, ubat cair darah lah, ubat cair darah. Okay, aspirin to reduce the viscosity of the blood to avoid thrombosis to happen lah. But exercise actually itself, it can become the anti-thrombotic. Okay, become anti-platelet, formation of platelet by decreasing the blood viscosity. At the same time, we will give other effects as well, other benefit effects. So yeah. So now let's go to the myocardial pumping dysfunction and heart failure. So we have discussed about how exercise can help to prevent from getting cardiovascular heart disease. And then once the patient or clients had the cardiovascular heart disease, how exercise can help them to improve their living. And now the third one is the I would say more into a patient who have cardiovascular heart disease due to non-modifiable factor. Other than due to inactivity. This might be due to the factor of wear and tear or heredity, age difference, and other than that, other non-modifiable. So myocardial pumping dysfunction can be due to modifiable and non-modifiable. Okay, the failure of hearts. So yeah. So what is the myocardial pumping dysfunction? It is the loss of ventricle ability to create enough blood pressure to circulate and perfuse blood to organ tissue. And then left ventricle dysfunction due to hypertension. Okay, due to hypertension because the due to ischemic factor, it can be that myocardial infarction, valve disease, it can be because of valve disease. Valve disease is nothing to do with inactivity. Hypertension can be because of inactivity, can also because of heredity. Okay, myocardial infarction. Hypertension, of course, will lead to myocardial infarction. Valve disease, diabetes, and hyperlipidemia. So these are factors that can make the left ventricle from efficiently function. So the symptom that you will experience when you have myocardial pumping dysfunction is shortness of breath, ankle edema, and pulmonary crepitations. These are the symptoms that we experience, and you can trace it from the ECG wave. Okay, and then these are the criteria of ECG wave to trace if someone experience or have myocardial pumping dysfunction or heart failure. So it is 10p there's two methods to measure or classify someone has myocardial dysfunction, okay, which are the 10P and 10Q, which I'm going to explain in a short while. So basically 10P must, if you look into the, the wave, the ECG wave, okay, the 10P is actually measuring the ventricle contraction time to allow blood filling and pumping of the blood once it's has fully filled. So that's what it means by the 10P and 10Q. Okay, so I'm going to show you a graph here. So this is 10P, 10Q, which basically explain the left ventricle, filling and pumping phase. Okay, this is the filling and pumping phase of the left ventricle. Okay, so yeah. Okay, let's first. Okay, I will come back to this formula later. So a left ventricle dysfunction is the amount of blood ejected is lesser than amount of blood filled. So that is what left ventricle dysfunction is. Okay, it's not being efficient because the amount of blood being ejected out from the left ventricle is less than the amount of the blood filled inside. So it's not strong enough to pump the blood. So it also refers as congestive heart failure of CHF. Okay, the dysfunction of left ventricle dysfunction. Ejection fraction is less than 50%. Okay, meaning that the volume that out, the blood volume that out from the heart is less than 50%. Okay, that can be classified the person to have congestive heart failure. Say the normal range is 65 to 70%. So it must be 65 to 70% of the total volume blood fill the left ventricle to out, okay, to pump out from the chamber. And during submaximal exercise, this should raise another 10 to 15%. So yeah, when you do exercise, usually your heart pumps stronger, so it will add additional of 10 to 15% from the normal range for the heart to supply blood across your body for particular demand, exercise demand. So, but ejection fraction in cardiovascular heart, for the congestive heart failure patient will decrease or worsen. So, for those who have CHF, congestive heart failure, the ejection will decrease or worsen due to, could be due to ischemic, due to, valve, dysfunction. It can be both from modifiable and non-modifiable factor. And since it's due to the non-modifiable factor, due to wear and tear, it could usually happens on individual of more than 65% years. More than 65 years old person. So as I mentioned, the 10Q and 10P is the indicator to determine if someone have CHF, congestive heart failure, or ineffective of left ventricle. So yeah, 10P is from end of T wave to the beginning of P wave. Okay, 10P is the end of T wave. Okay, end of T wave. Okay, if you remember the graph, okay, PQRST. Okay, the wave, if you remember, P wave, Q wave, okay, R, S, and then T. So these resemble electrical activity, or pulse of your heart activity. Okay, activity of your a pacemaker. Sorry, yeah, activity of pacemaker. So the first pacemaker, the first chamber. Okay. So yeah. So 10p is the T wave, the beginning of T wave until the P wave. Okay, 10p. Whilst 10q is end of T wave to the beginning of QRS complex. So both of them, resemble the activity of filling and ejection of blood in your left ventricle. So if the person, if the reading from T wave to the beginning of P wave is more than 331 millisecond, or 10q is more than 455 millisecond. Okay, if the persons achieve less than that, okay, less than this number of both 10p and 10q respectively, okay, in in the ECG reading, okay, that person will potentially have a CHF, congestive heart failure. Okay, so this is the ECG graph. Okay. PR interval is the contraction of upper chamber. So yeah, so P is the atrium, both left and right atrium contraction. Okay, filling contraction. This is the atrium contraction, and QRS is the pacemaker for lower ventricle, if you remember. QRS. Okay, T is the relaxation of the left ventricle. T is the relaxation. Okay, when the left ventricle, or the left and right ventricle relax, so it forms a T wave. Okay. Okay. If you remember this graph, P is the atrium contraction, or the first pacemaker. Okay, and then QRS is the ventricle, both ventricle pacemaker, both left and right ventricle pacemaker. And there is also I would say it's overlapped with the relaxation of the atrium chamber in here as well, because it's happened at the same time, so you cannot see the relaxation like this. Okay, relaxation of the atrium. Okay, because it's overlapped by the QRS wave, and then T wave is the relaxation of your ventricle. So basically, the end of T wave okay, the end of T wave, okay, the relax of a T wave, okay, until here, the beginning of QRS, okay, the relaxation. So this is where it starts to relax, okay, open to allow blood to fill in, okay, before the next contraction. This is the next contraction, QRS, contract. This is the feeling phase, okay, this is the feeling phase of the left and right ventricles, okay, end of T until the starting of QRS. So this is feeling. So if the person who have less timing, which is less than 445, okay, from here to here, okay, from the end of T to the beginning of Q wave, okay, less than that, meaning that the feeling, the contraction, the efficiency of the ventricle to contract is not efficient. The is low, is lesser. Okay, that's what it means. So yeah. So let me just show you here. So another way, 10p is RR interval, okay, minus PQ interval, okay, PQ interval. Where's PQ interval? PQ interval. Okay, here, basically here, PQ interval minus QT interval. This one minus QT interval, or 10Q is the RR interval minus QT interval. So minus QT interval, minus QT interval. So it will tell you, okay, tell you exactly the left ventricle activity of feeling and pumping contraction. So yeah. So that's how we can tell if someone's experienced the or someone's having myocardial pumping dysfunction or heart failure, CHF, congestive heart failure. So based on the ECG wave. Okay. So both 10p and 10q resemble electrical and mechanical functions of the left ventricles, as I mentioned, and the diastolic function of the left. Of course, the contraction is a diastolic function of your left ventricles upon lower heart rate. Okay, lower heart rate. This is to allow feeling. Okay. However, poor ventricle ejection or pumping, ejection of the blood, is not correlate to the aerobic exercise capacity in the muscle. So yeah, although the heart ventricle is not pumping efficiently, many studies have shown that actually it doesn't really have any strong correlation to the internal respiration, meaning that the ability of the muscles to absorb oxygen is the same no matter if you have congestive heart failure or not. Okay, the absorption, the perfusion of the muscles, the oxygen to the muscles or other tissue or other organs are the same. It's just that the problem is due to the left ventricle only, not due the internal respiration. Okay, so meaning that they still can perform exercise to increase. Okay, although their heart couldn't be fixed because of exercise. Let's say it is due to non-modifiable factor because of wear and tear of the heart. okay, but still exercise need to be encouraged to this population, so they are, they're not, just laid back, but rather, increase physical activity that can increase the perfusion of oxygen to other organ in the body, okay, under that, heart condition, okay. Of course, if it's because of modifiable factor, because of a clotting of or formation of plug in your carotid artery or artery in your heart, it can be fixed by exercise, by producing more HDL and act as a scavenger to the to the cholesterol plaque, okay. So exercise in primary prevention of congestive heart failure or myocardial dysfunction. Let me just, okay, enlarge this. So unlike cardiovascular heart disease, in neither lack of physical activity or low aerobic fitness is primary risk of congestive heart failure. This is what I mentioned just now. It could also due to other problem, okay, could due to other non-modifiable factor, okay. There is also other factor that could lead to congestive heart failure. But however, aerobic exercise and physical activity can be a preventive strategy to reduce the degree of prevalence. Of course, it could also, due to inactivity. It also could due to wear and tear or certain diseases. Okay, maybe your heart being infected by a virus or bacteria that make it swollen, and the pumping is not efficient, and the valve is a problem, and leads to congestive heart failure. But you also could do to inactivity. But above that, aerobic exercise and physical activity can be a preventive strategy to reduce certain degree of prevalence, meaning that although the heart is already wear and tear or have any non-modifiable factor that make it less efficient, of course, by doing physical activity will, as I mentioned earlier in this slide, it will bring you to few benefits that can increase the the well-being of the person. All right, where was I just now? Yeah. So exercise rehabilitation and secondary prevention of congestive heart failure. Limited evidence that shows exercise can prolong life for this disease, since it is non-modifiable. Okay, could also due to non-modifiable. However, exercise can improve the quality life to mild to moderate congestive heart failure, and several physiological elements needs to be considered when providing exercise to congestive heart failure, which I'm going to explain a little bit. So these are several physiological elements that need to be considered when providing exercise to congestive heart failure patient. The first is exercise can induce arrhythmia. Congestive heart failure patient, both congestive heart failure patient and also other cardiovascular heart disease patient could unable to maintain the rhythm of the heart. Okay, especially for those who have applied pacemaker or apply the stent in their heart, okay, or they do a bypass, they can't really, they are not, their heartbeat is not normal and doesn't really tell what is the exercise demand that's suitable to increase the heart rate. So it could lead to arrhythmia or irregular heart rate. So you have to be precaution that if you prescribe or monitoring exercise to this patient. So it independent to heart rate. So we have to see other variables such as RPE and also blood pressure. You can see blood pressure as well. Yeah. And then secondary skeletal muscle dysfunction. Okay. For those who have congestive heart failure, they're usually bed rest and they're not active, and potentially will have atrophy, meaning that their skeletal muscle is unhealthy, because they're not used to do activity. So you have to monitor on that. And their metabolism of their skeletal muscles is, we'll say, a bit different than normal people due to certain medication that they take. Okay. And then age. Okay, age need to be adapted to older people because as I mentioned, CHF, congestive heart failure, could also because of wear and tear, and wear and tear is usually happens to elderlies, as what I've shown in my previous slides. Those who are more than 65 years old will potentially will get congestive heart failure, and then older people. Hence, older people will usually have arthritis, sakit lutut, lack of flexibility and stuff. So these are the physiological elements that you need to consider when providing exercise to them. And then balancing between aerobic and strength training. You have to balance that between these two and make sure it's suitable to their age, okay, and their illness condition, their body condition due to their illness. And then impact to hydration or exercise capacity. And yeah, this is due to same like the second point here. Usually for those who have congestive heart failure will be prescribed with certain medication that will lead to certain changes in their physiological system. For example, as I mentioned, aspirin or beta blocker will lead to for them to have low viscosity, blood viscosity, and also could lead them to have edema at a certain degree. Okay, or blood pool a certain area, and then water retention and so could happen to them. Okay, so yeah, you have to be precaution on that when you're prescribing exercise to this population. So these are the graph that explains about the factors that influence the likelihood of arrhythmia during exercise. You can read this through, you can understand this graph. Okay, you can try to understand it. Okay, or what will lead to arrhythmia or irregular in heartbeat, heart rate. Okay, what are the factors that influence arrhythmia? Okay, factors that influence the likelihood of arrhythmia during exercise. So this is the first factor that I can explain. Okay. So yeah, now I'm going to explain you the consideration for exercise and cardiac medication. Okay, so when you receive a patient that have history or a background of cardiovascular heart disease or congestive heart failure, okay, you need to aware that they will consume certain medication that will affect their body physiologically, and then this will, you have to compensate. It will have a different adaptation to exercise, unlike a normal population. And this medication can positively and negatively interact with exercise. So these are 6 general areas of cardiac medication. General area that cardiac medication that will make change to the person's physiological system. Okay, certain medication can increase the coronary blood flow, which preserve or increase myocardial oxygen supply. For example, nitrate. Okay, nitrate can increase the perfusion of oxygen to the blood. So it seems like this will improve exercise performance because nitrate can increase oxygen consumption, okay, at least a certain degree. And then the second areas is reduce myocardial oxygen demand. Okay, beta blocker. Okay, if the medication contains beta blocker, it will reduce the myocardial oxygen demand, meaning that it will make the person calm by lessening the heart rate. Okay, the demand will be lesser to reduce the workload of the heart, so reduce the myocardial oxygen demand. So beta blocker. And then the third one is stabilize or maintain electrical control of myocardium. Okay, this is to prevent dysrhythmia. Okay, so there's certain medication that act as anti-arrhythmic to maintain the blood, to maintain the rhythm of the heart. Okay, and then there's a medication, is statin, that prevents atherosclerosis. Okay, statin is the medication that prevent atherosclerosis or hardening of the artery walls. Okay, so statin will soften or make the artery walls flexible. Okay, antiplatelets. Okay, decrease in blood viscosity, buat cair darah, to avoid further build up of thrombosis. So the person must eat medication that contain antiplatelets. Then last but not least, the control fluid level or diuretic. Okay, these are the 6 areas that cardiac medication have contained. All right, beta blocker is the diltiazem or verapamil. Okay, if you see this in their medication, this will act as to reduce the sympathomimetic. Okay, reduce the sympathomimetic, or reduce the effect of adrenaline and non-adrenaline. Okay, the sympathomimetic is the regulation of both adrenaline and non-adrenaline. Okay. And it will reduce the heart rate and force the myocardial to contract. Okay, entropic effect, which leads to decrease in myocardial oxygen demand and preserve oxygen in the carotid artery. the artery in the heart. So kind of to stay to make the blood stay or preserve the blood in the heart organ, in the heart cells, to avoid more ischemia to happen. So yeah, so beta blocker is actually reduce the heart rate, okay, to allow more blood to perfuse, okay, to perfuse oxygen within the cardiac muscles. So this will allow a period of diastole. Diastole means period of contraction, the ventricle contraction, okay, to preserve the greater times for coronary artery to fill and perfuse myocardium. This is those who have CHF, congestive heart failure, shorten in the filling time, and lower excretion of blood. So when they consume beta blocker, it will prolong the time of filling and prolong the time of the blood to supply oxygen to the cardiac muscles, and this will eventually decrease ischemia and arrhythmia. So that's the function of beta blocker. So along with beta blocker, usually a patient of CHF and CHD will also consume aspirin. Aspirin is the antiplatelets to prevent blood clotting, to prevent the formation of thrombosis. If you remember, when I explained in the pathophysiology of atherosclerosis or CHD earlier in slide, okay, the one of the factor that could lead to cardiac arrest or myocardial infarction is because of the formation of thrombosis, meaning the rupture of the endothelial cell of the artery bed, okay, and by consuming aspirin, it will reduce platelets and avoids the formation of thrombosis, okay, in case if the cap of the artery ruptured, okay. But you have to keep in mind when the person's consume aspirin, the blood viscosity will be lower, okay, cair sedikit lah, okay. And same goes with ACE inhibitor to vasodilate, to increase the stroke volume. It will expand the lumen of the artery. And then statin is lowering cholesterol. Okay. So these are the table that explain certain medication and how it affects the physiological of the patient. You can read this through. I will provide a slide for you for this. Okay. No more, like just 3 slides left. Okay. So yeah. So now let's look into the practical consideration of exercise and rehabilitation of cardiac patient. What things that you need to consider to assist your patient during exercise and rehabilitation. So warming up and cooling down, warm up and cool down during structured moderate to vigorous activity. Okay, please do 10 to 15 minutes of lighter activity. Okay, make them to perform 10 to 15 minutes of light activity to to improve blood circulation, to increase to prepare their body to perform exercise, basically. Yeah. So the warm-up should be graduate or gradually increase the intensity from rest and up to 40 to 50% of their VO2 max or VO2 max reserve, or 60% of heart rate reserve, if you want to using RPE Borg scale, it should be 9 to 11, somewhat mild to moderate. So gradually build up, okay, the patient's intensity gradually to slightly below moderate intensity. So the rationale behind this, it's form of a safety perspective, is that it takes this amount of time for the coronary artery to fully dilate, and correspondingly prevent acute rises in circulation, in circulating catecholamines, or catecholamines is the sympathetic stimulation that could irritate the myocardium. So when you slowly build up the intensity of the exercise, okay, it will prevent the accumulation of catecholamines that will stressing the myocardium, and also slowly increase or vasodilate the carotid artery. And for the exercise performance perspective, this will allow enough time for the shunting of blood from the viscera to skeletal muscles, the lung, the heart, and the skin. So it's kind of preparing your body and ensuring the skeletal muscles is adequately perfused of oxygen, okay, to meet the demand of the aerobic metabolism to happen when doing exercise later. All right, so and then apart from warm up, after you do exercise, do cool down activity, moderate gradually to low intensity. Okay, start from moderate and then slowly to gradual intensity to clear the lactic acids and the catecholamines, because a study has shown that by performing a good cool down, okay, it's actually better in eliminating lactic acids and catecholamine compared to immediate rest. Okay, when you immediately rest, the lactate and catecholamines will I would say elimination will become slower. Okay, it's slower compared to if you do a gradual reduce of intensity during the cool down. Okay. So of course, by doing cool down, it helps the heart rate to achieve resting level with venous return sooner than immediate rest. Okay. Okay. And then other factors that we need to consider is the posture, movements. Okay. Is it not advisable to get patient to perform activities in supine position after dynamic upright activities? Okay, I will explain to this why. Okay, during submaximal exercise, for given oxygen uptake, cardiac output is greater in supine, okay, than in upright position. Okay, the implication of this for cardiac patient is that the greater cardiac output, the greater the myocardial oxygen demand, which increase the likelihood of ischemia and ischemia-related events. So yeah, avoid to change, position drastically, and then quick change of position and posture will increase blood flow towards the thoracic cavity and trigger angina in a CHD patient. Okay. So it is also not advisable to get patient to immediately perform upright or seated position after supine. So this is a vice versa of the first point. So don't do lay down and suddenly quickly get up straight, okay, because this will lead to sudden decrease in systolic and diastolic pressure, that lowering venous return to heart, and reduce the aorta pressure will invoke ischemia and myocardial. Yeah. So these are the posture movement that you need to keep in mind when you assist your patient in doing exercise. Okay, example, burpee is not the best exercise for CHF and CHD patients, of course. So yeah. So for that, that's the end of this lecture. Thank you very much.